Good morning, everyone. So thank you to coming to today's Grand Rounds, both virtually and in person. Today with us, we have Dr. Reeves, who's an assistant professor in the Department of OBGYN, specializing in complex family planning. And she also has a master's of public health from Emory. She's the perfect person to teach us today about abortion and healthcare for pregnant women. This topic's more timely than ever, and we're really fortunate for her to be with us today in order to teach us about the implications of Dobbs v. Jackson and how it's impacted healthcare. So thank you for coming, Dr. Reeves.
Well, hey, good morning. It is my distinct pleasure to be here. I'm so happy to have been invited because this is near and dear to my heart, both professionally and personally. So briefly, I have no financial disclosures, but I do have a deeply held belief that a person who is pregnant is the only person who has the right to decide what happens to that pregnancy. Our objectives are many. We're going to review the epidemiology and public health of abortion access in the United States, discuss the historical and legal context for abortion in the United States, and now currently the legal status of abortion care in Missouri, what impacts Dobbs v. Jackson might have for us as healthcare providers, and also to develop action steps. What can I do? So let's start with a little bit of background. Abortion is an important part of healthcare and the reproductive lives of our patients. However, it continues to be highly politicized, which often makes the medical aspects of our job difficult to separate from the political and cultural. We know that abortion is very common. Based off of epidemiological data, 1 in 4 pregnancy-capable people will have an abortion by age 45. Two big organizations in the United States, the Guttmacher Institute and CDC, perform abortion surveillance to monitor abortion counts, rates, and ratios. And in 2017, 18% of pregnancies ended in abortion. This graph on the right shows data from Guttmacher Institute up to 2017, where abortion rates have changed over time. It peaked in the 1980s at 29.3 abortions per 1,000 reproductive aged women and has steadily decreased until 2017. However, newer Guttmacher data from 2017 shows an 8% increase in abortion counts, resulting in an abortion rate of 14.4. However, this is still below 1973 levels. Who has abortions? Characteristics of people who have abortion vary, but most are in their 20s. Most have a prior live birth. Most report that they are religiously affiliated, and most are poor or low income. When do patients seek abortion? Most abortion occurs in the first trimester. In 2019, approximately 93% of abortions reported to CDC were performed at or less than 13 weeks. Abortion in the second trimester occurs for various reasons, including health indications, fetal anomalies, patients who didn't know they were pregnant, or, important to what we'll talk about today, sometimes because of barriers preventing access to abortion in the first trimester. This figure shows how medical and surgical abortion is performed by weeks duration of pregnancy. First trimester surgical abortion is accomplished via dilation and curettage, D and C, where the cervix is sequentially dilated and the uterine contents are aspirated, either manually as shown, or with electric suction. In the second trimester, uterine instrumentation is often required to completely evacuate the uterus. And so the name of this procedure changes to dilation and evacuation. Medication abortion is also available, both outpatient and inpatient. Outpatient abortion via medication is with mifepristone, an antiprogestin, and misoprostol, a prostaglandin E1 analog. And that can be done safely up to 77 days or 11 completed weeks of gestation. In the second trimester, we admit people to the inpatient service and perform a labor induction abortion, again using medications like mifepristone, misoprostol, in addition to other means to help dilate and evacuate the cervix. Over the last decade, a greater proportion of abortions were performed via medication abortion. In 2001, early medication abortion only accounted for 5% of abortions, whereas in 2017, that increased to 39%. And although not shown here, CDC surveillance data suggests that in 2019, over 50%, 53% of total abortions were performed via medication. Finally, it's worth noting that abortion is safe, whether preferred via medication, surgery, whether performed in the first trimester or second trimester. This is particularly, but not exclusively true, where it is legal, accessible, and performed with modern medical techniques. As demonstrated by this figure, abortion complication rates are low and well below common complication rates of common procedures such as tonsillectomy and wisdom tooth extraction. And I think most of us in this room are aware that the risk of death from childbirth is much, much higher. So looking at this a little bit more closely, because of legalization, advances in technology, including the use of vacuum aspiration, abortion morbidity and mortality have remained low. This figure comes from older data in the 1980s and 90s, but even so, the risk of death associated with abortion is low. And I have included the net figure from CDC 2019 of 0.41 deaths per 100,000 abortions. The risk of death when a pregnancy is continued to full term is about 12 times as great as the risk of death associated with abortion. Finally, abortion is safer the sooner in pregnancy that it is performed. So from the rest of this figure, you can see through the first trimester, 12, 14, 15 weeks, mortality rate from abortion is incredibly low. However, it does increase the farther the duration of the pregnancy increases. Overall, there is less than 1% risk of major complications. Multiple systematic reviews have shown no long-term increase in infertility, miscarriage, ectopic pregnancy, birth defects. There is no association between abortion and breast cancer. There is no association between abortion and long-term mental health problems. Briefly, just to show you the types of complications that are associated with resulting in mortality from abortion: infection, hemorrhage, anesthesia complications. Looks pretty similar to our complication risks associated with pregnancy and term delivery. This is important context to set because worldwide, complications from unsafe abortion still occur, and approximately 13% of all maternal deaths are associated from unsafe abortion. In total, 3 million people may be admitted to hospitals for complications from unsafe abortion, and virtually all these deaths and injuries occur in the developing world. Legality plays an important role here. From WHO data, the countries that ban or severely restrict abortion access, only about 1 in 4 are characterized as safe. Whereas in countries that allow abortion without restrictions, 90% of these abortions are classified as safe. As we'll talk about more later, restricting access to abortion does not eliminate abortion. So let's dive in to talk a little bit more about the legal context of abortion care in the United States. As with many public health issues, there are complex and interconnected spheres of influence on how abortion is provided and how people access abortion in the United States. Perhaps most prominent is this legal context, referring to the set of federal and state policies on abortion access. Certainly, the cultural and legal status of abortion has changed over time, so let's spend a little bit of time talking about that. Prior to the Constitution, abortion was legal before quickening, or that moment in gestation where you may start to feel fetal movement. Laws banning abortion first appeared in the 1880s, and by 1910, 47 states banned abortion. These laws fell under Comstock, or anti-obscenity laws, and our own American Medical Association lobbied for the criminalization of people who received an abortion and people who provided abortion. Fast forward to the 1960s, I want to talk a little bit about this person pictured here, Jerry Santoro. In 1964, Jerry Santoro was 28 weeks pregnant when she and her partner performed a self-managed abortion using surgical instrumentation. Her partner fled when she started to bleed, and the maid found her in the hotel room the next day dead. I'm not going to show you the infamous picture of Jerry kneeling face down on her hotel room floor with a towel tucked between her legs, but this image has been a symbol for abortion reform in the 1960s and 70s. We will likely never know the number of illegal abortions performed in the United States, but it's estimated to be somewhere between 200,000 and 1.2 million. However, before the legalization of legalization of abortion, complications were common. This photo is of a patient receiving care at Cook County Hospital, where many other hospitals also had to perform or open post-abortion wards to take care of folks suffering from complications of illicit abortions. These complications may include pelvic organ injuries, hemorrhage, dangerous clostridial infections, and sepsis. With all that groundwork laid, let's talk about Roe versus Wade. This decision involved the case of Norma McCorvey. She was known under the legal pseudonym of Jane Roe. In 1969, she became pregnant with her third child, and this was an unexpected and undesired pregnancy. She lived in Texas, where abortion was illegal at the time. So her attorneys filed a lawsuit on her behalf in U.S. federal court. After the District Court for the Northern District of Texas ruled in her favor, Texas appealed directly to the Supreme Court. And in January 1973, the U.S. Supreme Court voted 7-2 in favor of McCorvey and allowing the constitutional right to privacy as covering the right to abortion. But it also ruled that this right is not absolute and must be balanced with the government's interests in the pregnant person and the unborn child. And so this benchmark was set at viability. This is important from the public health perspective because this maternal mortality immediately dropped in the 1970s as individual states and later the nation in 1973 started to liberalize abortion law. So this graph shows abortion mortality rate over time dropping. Of course, Roe versus Wade is not the only legal case in abortion care. Another key case to talk to you about is Planned Parenthood v. Casey. This was a case that upheld Roe versus Wade, but SCOTUS made a provision to allow states to regulate abortion so long as there was not, quote, an undue burden on the person seeking abortion. Using this benchmark of no undue burden, individual states have constructed a latticework of abortion law, codifying, regulating, and limiting whether, when, and under what circumstances a person may obtain abortion. These types of laws included mandated counseling materials, parental consent laws, mandatory waiting periods, ultrasound requirements, gestational age limits, and many, many more. So let's take a look at Missouri and Illinois as examples of the patchwork access to abortion in the United States. Even prior to the Dobbs decision in June, Missouri had some of the most restrictive regulations on abortion. In the state of Missouri, the same physician that intends to perform a patient's abortion must be the one who signs a consent form and provides state mandating counseling at least 72 hours prior to the procedure. We have a 22-week gestational age limit, except medical exceptions. Private and public insurance policies are prohibited from covering abortion costs, and minors are legally required to notify both parents and obtain consent from at least one parent to have an abortion. Comparatively, Illinois has laws that to expand and protect abortion. For example, abortion may be provided by physicians, nurse practitioners, and even PAs. Medicaid is required to pay for abortion. There is no gestational age limit, and minors are allowed to consent for themselves without notification or consent of a parent. Legal regulations create barriers to access. Delays in care lead to increased numbers of patients seeking abortion in the second trimester. For example, after the passage of Texas HB 2, which was a Texas law that required abortion providers have hospital admitting privileges, half of the healthcare centers that provided abortion care closed. This decreased the total number of abortions performed in Texas, which was perhaps the goal of Texas legislators, but the proportion of abortions at the second trimester increased. As has been studied over and over again, abortion restrictions do little to improve the health of people seeking abortion, and instead create additional barriers and obstacles to overcome. This graphic on the right shows pictorially some of these barriers. including if needing to travel farther, needing to take more time off work, to raise money, to find childcare, to arrange lodging and transportation, all of which can further delay the care people seek. So let's talk about HB 2, which is in the case of Whole Women's Health v. Hellerstadt. This was the case that challenged the Texas law requiring hospital admitting privileges. SCOTUS ruled that the law was unconstitutional because it violated Planned Parenthood v. Casey. Closing half the clinics as a result of this was an undue burden on patients, since they now are traveling hundreds of miles to seek care. Now let's talk about Dobbs v. Jackson. This case challenged a Mississippi law that banned abortion after 15 weeks estimated gestational age. 15 weeks is not viability, so this would be unconstitutional under Roe. But after it was overturned by 2 other courts, it was finally heard before SCOTUS in December of 2021. And then early in the morning of June 24th, 2022, the Supreme Court issued their ruling on Dobbs v. Jackson. SCOTUS upheld Mississippi's 15-week ban. In so doing, overturned Roe versus Wade and Planned Parenthood v. Casey. The majority opinion argued that there was no federal protection for abortion, that abortion should be decided by the states. The immediate fallout of Dobbs v. Jackson has been apparent. As of earlier this week, 13 states, including our own, have banned abortion with very limited or no exceptions. Ohio just had their 6-week ban temporarily enjoined, leaving Georgia as the only state here in orange, which bans abortion after 6 weeks or when a heartbeat is detected. Scholars believe that as many as 26 states are estimated to ban abortion in response to overturning Roe versus Wade. So what does abortion access look like in Missouri? Missouri was the first state to enact a trigger ban, outlawing abortion except for cases of medical emergency. According to the state of Missouri, a medical emergency is a condition which, based on reasonable medical judgment, so complicates the medical condition of a pregnant person as to necessitate the immediate abortion of that pregnancy to avert the death of the pregnant person, or for which a delay will create a serious risk of substantial and irreversible physical impairment of a major bodily function of the pregnant person. This seems wide enough, but it has fallen to individual hospitals, physicians to help interpret this law, which we'll get into. Certainly, there are medical emergencies in OBGYN. I think many of us are familiar with hemorrhage, sepsis, placenta accreta spectrum leading to hemorrhage, acute stroke, MI, respiratory failure as a result of COVID. All of these may constitute a medical emergency. Importantly, when you have a pregnant person in your practice who has high-risk medical conditions, you should engage with OBGYN early and often. We are now practiced in diagnosing and documenting when such medical conditions might exact a medical emergency. We are unlikely to ask you as our consultants to justify or document a medical emergency, but we may ask you for pre-op or post-op recommendations. So a little bit more about us. We have a division of family planning who specializes in complex contraception and abortion care. The Washington University Family Planning Service consists of 4 attending physicians and 2 fellows. We have a complex family planning fellowship, which is 2 additional years after OBGYN residency. And we have a Ryan residency curriculum, which is a specific curriculum to train residents in abortion and complex contraception. Previously, we provided medical and surgical abortion here at the hospital for high-risk pregnancy conditions and fetal anomalies. Now, in accordance with state law, we only provide abortion for medical emergencies. Important again to mention is that routine OBGYN services are unaffected by this law. The management of fetal demise and ectopic pregnancy are the same. These are not abortions. Contraceptive services are unchanged. Modern contraception is not abortion. Where can our patients go to access abortion? There are 2 outpatient abortion centers in Southern Illinois, Hope Clinic for Women in Granite City, and Planned Parenthood of the St. Louis region has an affiliate in Fairview Heights, Illinois. This is where we routinely refer our patients who do not meet medical emergency criteria. All right, so let's talk about what we're really here to talk about. What does this mean for us as healthcare physicians, and what are the wider public health implications of this SCOTUS decision? So let's go back to our social ecological model. Never mind that there are very real consequences for the individuals and their families. What stigma will they face now as they navigate this new climate? What will be their health outcomes? Will we see an increase in maternal mortality as a result of abortion being illegal? At the institutional level, Dobbs v. Jackson affects us as healthcare practitioners. So many of the state's abortion trigger bans include criminal prosecution statutes, which few healthcare providers are willing to risk. This results in a chilling effect, such that providers and their institutions may act more conservatively than state laws just to avoid excess risk. There are concerns how Dobbs will affect our medical schools. How will medical students, residents, and fellows be trained in abortion so that they can be knowledgeable physicians and be able to take care of people no matter what their specialty? Will this lead to brain drain, such that physicians and trainees will leave states that have abortion bans, further restricting healthcare access to the places that need us most? As a result of all of this, how will we treat our patients if we know that they have attempted an abortion themselves or have traveled across state lines for an abortion? Abortion stigma affects us too. Moving up the social ecological model, how will the Dobbs decision and overturning of Roe versus Wade affect our communities, our health and healthcare access? What have we learned from other countries where abortion is illegal or whose legality had changed as suddenly as ours? And yes, abortion stigma acts here as well, particularly around cultural opinion, secrecy, shame, and at the public health standpoint, how do we measure abortion if no one's willing to talk about it? Finally, there's little evidence that local, state, and national politics will stop with Dobbs v. Jackson. What else is on the horizon? All right, so for the sake of recency, let's start back at the top and work our way down. Most recently, the US Senate has introduced a bill that would ban abortion at the national level at 15 weeks gestational age, which is the same gestational duration as was challenged in Dobbs v. Jackson. This bill is not yet scheduled for a committee or a vote. As for potential protection of abortion at the national level, the US House of Representatives has now passed twice this Women's Health Protection Act, which would create new federal protection for people and providers performing abortions. And this would extend nationwide despite state level bans. A companion bill to this that was also passed in July is the Ensuring Women's Right to Reproductive Freedom Act, which would prohibit interference with people crossing state lines to obtain legal abortion. This also provides protections for the providers who may provide abortion out of state or hold medical licenses in multiple states. And speaking of interstate travel, due to the patchwork access of abortion pre-Dobbs, many people already traveled great distances, but this heat map shows that if all high-risk states were to ban abortion, the travel distances to obtain abortion will increase. Here in white, you can see the average travel distance being less than 50 miles to obtain abortion. And the dark blue indicates that people would have to travel greater than 200 miles to seek abortion care. Pre-Dobbs in 2019, the average distance traveled to seek abortion was 25 miles. And again, this average would increase to over 100 miles. So again, talking about interstate travel, analysts expect that states on the individual level will start to ban interstate travel for abortion or target providers who have multiple medical licenses. For example, if someone has a medical license in both Missouri and Illinois and travels to Illinois to provide abortion, could the state of Missouri exact action against their Missouri license, even if they performed a legal abortion in Illinois? We should hope not, but we cannot put anything past Missouri. All right. Briefly, some states have already legislated some protections for abortion access or are considering these. Again, in our neighboring state of Illinois, they have passed a Reproductive Health Act in 2019, which eliminated a lot of barriers and codified the right to abortion in Illinois. And then the Youth Health and Safety Act passed earlier this year, getting rid of their parental notification law, such that minors may seek abortion without notification or consent of a parent if necessary. Moving on. The Dobbs decision and overturning of Roe versus Wade affects our community health and healthcare access. And here we have some evidence from the effect of such laws globally. I showed this slide earlier regarding global health of abortion access and abortion safety. Bears repeating that it has been demonstrated again and again that restricting abortion does not eliminate abortion, but it can compromise the safety of abortion and impact public health. The Center for Reproductive Rights helps track the world's abortion laws, which are broadly categorized by available on request, broad indications for socioeconomic and health, to preserve health, to save the life, or completely prohibit abortion. Now, the United States gets to have a fun multicolor because we now vary subnationally. It bears noting that the 82 countries with the most restrictive abortion legislation are also those with the highest incidence of unsafe abortions and abortion mortality ratio. But besides abortion complications and mortality, how else does this affect pregnant people? Two global public health measures are unintended pregnancy rates and abortion rates. This helps us determine and see what the trends are in people having access to prenatal care and abortion. This graph from Guttmacher summarizes 2020 global data by legal status of abortion. In dark teal, the unintended pregnancy rates appear higher in countries with abortion restrictions or prohibitions. And in the green, despite differing legal status, abortion rates are similar across groups. Again, pointing to the fact that no matter where you are in the globe, abortion access is critical to the lives of our patients. When stratified by country income, unintended pregnancy and abortion rates look a little different. From low and middle income countries, unintended pregnancy and abortion rates are higher than higher income countries, pointing to a correlation between healthcare access and public health outcomes. Although, if you look to the right of the graph, you can see that in middle income countries have a higher abortion rate, so pointing to the complexity of this issue. Visualized another way, this heat map shows unintended pregnancy rates by country and region, and abortion rates by country and region. Kind of going back and forth, you can see that in general, places where unintended pregnancy rates are high, abortion rates are higher. Again, pointing to the broader need for public health intervention for unexpected unintended pregnancies. There are many examples across the globe of public health consequences of severe abortion restrictions, especially maternal mortality and unsafe, illegal abortions, as we've talked about. This is a case study of Romania, who in the 1960s to 80s had a very pro-natalist leader who wanted to reverse the country's declining fertility rate. So he banned abortion and outlawed contraception. Under these policies, Romania had the highest recorded maternal mortality ratio in Europe, 170 maternal deaths per 100,000 live births. 87% of these were attributed to abortion complications. This leader was executed in 1989, and the new government immediately repealed these laws, and there is an immediate drop of maternal mortality. So that's a pretty severe example, but based on these and other data, some anticipated effects of Dobbs at the public health and community levels here include lower abortion rates in banned states, higher abortion rates in legal states, higher unintended pregnancy rates in banned states, and maybe higher contraceptive uptake, especially IUDs, implants, and sterilization. If you have any OBGYN colleagues and you ask them who's coming for contraception, anecdotally, it is true that we are seeing so many requests for sterilization right now. I think because of fear of unexpected pregnancy in a post-Dobbs world. This heat map shows anticipated drops in abortion rates should all high-risk states ban abortion. Areas of dark red in this heat map show then a more than 40% decrease in abortion rates. Moving back down, let's talk about the anticipated impacts at the institutional level, our hospitals, our universities, ourselves. The confusion and lack of awareness about how these provisions will be applied has an immediate chilling effect on reproductive care. The chilling effect is an inhibition or discouragement of the legitimate exercise of natural and legal rights by the threat of legal sanction. Basically, people will provide or withhold medical care due to confusion or fear of the legal repercussions. Think earlier to this year, Texas's 6-week abortion ban. There was a study of in-depth interviews conducted with Texas OBGYNs pointing to some of this confusion, and some of these physicians reported that at the institutional level, their institution was advising them to not refer for abortion, not to provide options counseling, all for fear that this may be considered, quote, aiding and abetting, which is some specific language that comes from the Texas law. Previously, there's been litigation about D&E bans. Although a D&E is not used just for abortion, it could be used for a retained placenta. It could be used for a fetal demise. This procedure is common in OBGYN, yet some providers may be unwilling to perform this procedure due to fear of it being akin to an abortion. We've also already seen in the state of Missouri, in the immediate fallout of Dobbs, certain hospitals, physicians stopping certain contraceptive services, i.e. emergency contraception, due to fear that the state of Missouri would misinterpret that as an abortion. And we heard horror stories of people delaying treatment of folks with ectopic pregnancies because of fear that that pregnancy having a heartbeat would be considered an abortion. It bears repeating that emergency contraception and IUDs are not abortifacients. The medical and surgical management of ectopic pregnancy are not abortion. This has actually been clarified by the Missouri Attorney General and the Missouri governor. Missouri law does not prohibit the use or provision of Plan B or contraception. And Governor Mike Parson said, contraceptives are not abortions and are not affected by the Right to Life of the Unborn Child Act, which is the name of the Missouri law. But these statements do not change that some physicians and support staff will be hesitant to provide care, even in the setting of a legal exception to abortion care. Although it is primarily OBGYNs, and here the complex family planning person, who's going to take on that primary legal burden of justifying what is a medically necessary abortion, we rely on our colleagues in other departments to aid in hospital-based care. My fellowship thesis was a qualitative study exploring anesthesia providers' perspectives on abortion provision. At the time, Georgia had passed a 22-week gestational age limit, and so we were curious how anesthesia providers might respond to the potential legal consequences of providing anesthesia for abortion in cases that might meet medical exceptions. The chilling effect was a major thematic finding here. One mid-career anesthesiologist at a private hospital said, "Number one, am I going to get sued? I'm sorry, maybe that's not the right thing to say as a doc, but I'm not going to jail for this." And another certified anesthesiologist assistant at a teaching hospital said, "I feel like, unfortunately, a lot of mothers who might get sepsis or who might be in danger now will have to get sepsis before the abortion is done. Self-preservation is going to overrule the safety of the patient." The Dobbs decision is anticipated to affect medical training as well. About half of OBGYN residencies are in abortion ban states. The new laws may make OBGYN residency programs in red states less attractive, since medical students will not be able to receive the same quality of training they might where abortions are not regulated as strictly. In an article sent out to its members after Roe was overturned, the Association of American Medical Colleges, AAMC, predicted that the U.S. Supreme Court decision will make it harder for future OBGYNs and other providers to get training on how to perform abortions. This is a picture of the ACOG, our American College of OBGYN District 1 chair, who said, "Who wants to practice in an environment where you could be arrested trying to provide care that is evidence-based?" These restrictions may also affect our colleagues in other medical subspecialties, such as yourselves. If this affects how we learn about medical management of miscarriage, or even how to take biopsies. All right. Finally, let's come back down to how Dobbs will affect our patients and their families. For pregnant people seeking abortion in states where it is illegal, there are 4 possible outcomes for those pregnancies. They may continue their pregnancy to parent. They may continue their pregnancy with plans to adopt out. They may go out of state to obtain an abortion, or they may try to self-manage an abortion. So self-managed abortion care is one of the many terms used now to describe an extra-legal abortion or abortion care obtained outside of the formal mainstream medical care. As previously discussed, prior to Roe versus Wade, many patients attempted in self-managed abortion, not without risk. Thankfully, modern-day self-managed abortion will likely look much different, primarily focusing on mifepristone and misoprostol, which are readily available online. However, people who don't have access to this may still use herbs, abdominal trauma, instrumentation to eliminate an undesired, unexpected pregnancy. Additionally, studies already show that people are managing their own abortions already. Back in 2014 in Texas, a survey of people seeking legal abortion showed that up to 7% of them had tried to manage their own abortion prior to presenting to an abortion clinic. How will we as physicians and healthcare providers interact with our patients who self-manage their abortions? I think many of us are worried about the potential fallout from learning that a patient performed their own abortion, especially if they present with complications like bleeding. First, there is no law in the state of Missouri prohibiting post-abortion care. The short answer is that you should always take care of the patient in front of you, as you always would, to your level of training and scope of practice. It is not our duty as clinicians, nor is it a reporting requirement, to find out who did or did not try to self-manage abortion, because people who present with self-managed abortion will be indistinguishable from people who are having bleeding in early pregnancy or with a miscarriage. Patients may also be scared to disclose a self-managed abortion. Clinicians should always reassure patients that they will protect their confidentiality and prioritize their autonomy. Along those lines, it is important to avoid questions about where or how they got medications, as those details are not pertinent to the patient's clinical care. What about the patients who continue their pregnancies after being denied an abortion? Thankfully, we can turn to the Turnaway Study, which was a large 5-year cohort at 30 US sites providing abortion care. Almost 1,000 women were followed for up to 5 years, and people were classified as near limit patients, meaning people who presented in the 2nd trimester under that state's gestational age limit and received their desired abortion, or the folks who showed up too far along. These folks were turned away from abortion care. This study has been, and they've looked at multiple outcomes that we will review some of. This has been a pivotal study because it is comparing people seeking abortion. Typically, classically, we may compare people seeking abortion and their outcomes to people who are giving birth, but those populations are so incredibly different. And so this study has been very pivotal in determining what are the true risks of abortion or being denied an abortion. So let's talk about some of these outcomes. Women who were turned away and went on to give birth experienced an increase in household poverty lasting at least 4 years. They were more likely to not have enough money to cover basic living expenses like food, housing, and transportation. Being denied an abortion lowered that person's credit score and increased their amount of debt. Women turned away from getting an abortion were more likely to stay in contact with a violent partner compared to those who attained their desired abortion. By 5 years, women denied abortions were more likely to be raising their children alone, without family members or male partners, compared to women who received an abortion. Carrying an unwanted pregnancy to term is associated with poor maternal bonding, such as feeling trapped or resenting the baby. And being denied an abortion impacted those children as well. They were more likely to be born and live under the federal poverty level, and they were more likely to not be meeting just developmental milestones. Adding to what we already know about the outcomes of giving birth and abortion, people who were denied an abortion were more likely to report worse health outcomes, especially during pregnancy. Preeclampsia, postpartum hemorrhage, and tragically, 2 people died in childbirth as a result of being denied an abortion. There were no deaths in the abortion group. This leads us to talk about maternal mortality, which is already increasing in the United States for a variety of reasons. This graph is from CDC's National Center for Health Statistics and shows a higher maternal mortality rate among non-Hispanic Black people compared to totals. Although this could be an entirely separate lecture to talk about how racism affects us in maternal child health, it is important to remember that such inequities are predicted to worsen with these abortion bans. So what about the option of adoption? Well, the Turnaway Study looked at that too. Most women who received abortions were aware of, but uninterested in adoption. A minority of women who were denied abortions, about 230, were considering adoption at 1 week, but by 6 months, only 15 had managed to adopt out their child. That said, the people who did choose adoption were highly satisfied with that decision. But authors conclude that likely this is a complicated decision for folks, and it shows that people do not always consider adoption. Therefore, adoption is not going to be the automatic alternative to abortion that we may wish it is. All right, so maybe that's enough doom and gloom. Let's talk about what we can do about it. Certainly, a few things we can all do for our patients, regardless of our specialty and clinical context, is to assess pregnancy intentions, especially those of our patients who have comorbid conditions that might make pregnancy more risky. Do they have a plan to safely get pregnant? Are they trying to avoid pregnancy? How are they trying to avoid pregnancy? In people wanting to discuss their contraceptive options, refer them to us at the Contraceptive Choice Center, which is a Title X funded clinic that the Family Planning Division runs. There are also things that you can do to advocate on behalf of your patients. In family planning, we commonly refer to this as big A advocacy and little a advocacy. There is the big A advocacy things that you can do. Call and write your state representatives. This is the list here for zip code 63108. You could write an op-ed, you could go to Jeff City with us and testify. Probably most of us prefer to do the little a advocacy. How do we advocate for our individual patients? How do we educate and empower them? And if you have some spare money, maybe we can donate to reproductive health funds. Finally, know who to call for referrals. So this is a list of all of our contacts on the left side. Our family planning fellows hold a pager to help answer questions about people who may be pregnant and may meet those medical emergency criteria. I've already alluded to our Contraceptive Choice Center, which is our Title X clinic to provide low or no cost contraception. Or they can see one of us in the faculty practice on CO7 or the resident practice on CO3. If you have folks who disclose to you that they want to seek an abortion, there is no gag rule in Missouri, so you can tell them about abortion options in Southern Illinois. And this is the information for the Hope Clinic for Women and Planned Parenthood of the St. Louis region. In the state of Illinois, there's also the Regional Logistics Center that may be able to help with transportation, funds, lodging, et cetera, for people who travel to Southern Illinois for abortion. Okay, so to wrap up, abortion is common and safe. Abortion care and access is complicated here in the United States, thanks to its patchwork legal status. Dobbs v. Jackson is anticipated to have significant public health implications for our patients, communities, and ourselves. We should each continue to provide compassionate, confidential care and refer when appropriate. And finally, we each should advocate for our patients' healthcare access. I'm sincerely grateful for this opportunity, and I'm happy to answer any questions.
That was a terrific talk. Thank you so much. I really appreciate you being here, number one, giving this talk and really educating us. I think we have time for some questions. Any questions for the audience? Maybe one question I have is, I think there's still not enough information about emergency contraception and how and who could prescribe that. So how do you feel about primary care doctors, internal medicine, other than, you all prescribing emergency contraception? Could you tell us a little more about that?
Yes. The
Sure.
question is about,
You should have
various-
the mic.
okay, yeah, I also have my
Okay.
mic. I'll stand away and make sure there's no feedback. Yes, if in people who are trained about and educated about emergency contraception, you all can provide it. There are 3 major emergency contraceptives available. Plan B, which is a single pill that you can take up to 72 hours after unprotected intercourse. There is Ella, which is ulipristal, which you can take up to 5 days after unprotected intercourse. And then the copper IUD, which can be placed again within 5 days of unprotected intercourse, and obviously has the benefit of being ongoing contraception. But yes, in folks who are wanting to get exposure, more education about that, I would turn you to Innovating Education. Just Google Innovating Education and they can give you some webinars about that, or come follow us in our Contraceptive Choice Center if you need some more hands-on experience.
Thanks. Other questions? Can you check and see?
And I'll check the chat. see if
Okay.
there's any, but especially in our primary care clinic, we'll have patients that, there's so much on the internet and whatnot. What would you recommend us to say to patients that just ask, is it safe to be pregnant in some of these states?
So the general advice would be, well, in folks who are even planning pregnancy or worried that maybe unexpectedly get pregnant, how do you optimize your health care and seek early prenatal care? I think that's going to be the biggest takeaway. Certainly in people who are having ambivalence about a pregnancy, they're not sure what their outcomes are. It is safe, obviously, and legal to discuss those options. And I think people feel reassured by the fact that they don't have to make a decision today. Yes, abortion is safer the earlier that you do it, but abortion is legal in Illinois up to 24 weeks. And so people do have time to make that decision. They should not need to feel rushed.
Thank you.
Dr.
And then,
Reeves, maybe to your slide about what can we do and advocacy, both in the big A and the little a, we should put register to vote and vote.
Yes, that's a great addition.
And so particularly in the state of Missouri, we have a very important Senate race in which Eric Schmidt, the Attorney General, is running for Senate against Trudy Valentine, the Democratic candidate. They have very different opinions about reproductive freedom and reproductive rights. So I would encourage people, to register and to vote across the country, really, because I think the fundamental way to overturn some of this is really to get more people voting.
Vote, vote, vote.
and looks like we have a couple questions in the chat. So one of them is just talking about how it seems like a lot of our OB-GYN colleagues are just being attacked publicly and threatened publicly. So how are OB-GYNs just coping with Roe v. Wade? And then do you see practitioners leaving areas with the ban, things like that?
Yeah, so that is a pretty powerful question because, me personally, when I was deciding what I wanted to do with my life, I couldn't escape the true passion I had for people and providing a care for folks that people are afraid to be trained in because of those personal safety concerns. And I think that's really coming up to the forefront again. I'm not aware, besides the in-depth interviews that were conducted with the Texas OBGYNs, I'm not aware of any yet published studies with what public opinion of OBGYNs is, although I anticipate those are being conducted. But anecdotally, I've been advised maybe I should move to Illinois, maybe I should not have a house in Missouri. How do I protect myself, make sure the crazies don't find me? Part of that is an individual decision on how out you want to be. But it's a very real concern.
No, absolutely. And then another question is just, especially it seems like Illinois is still an option. Do you know insurance coverage for patients? Is that available if they're a Missouri resident?
So unfortunately, if they have a Missouri-based insurance plan, the state of Missouri prohibits private or public plans, meaning Medicaid, to cover abortion services. However, any Illinois-based insurance plans do cover abortion, and Illinois Medicaid do cover abortion. So very rarely we'll have folks who may be Missouri residents, but because of their job, they have Blue Cross Blue Shield of Illinois. Those folks may have insurance coverage.
Oh, wonderful. And then another question is, have you had to consult with lawyers to determine medical emergency?
Yes, yeah. So before the talk, we were chatting a little bit about this has been a long time coming, and actually, thankfully, we've been very supported here at WashU. So months before Dobbs, we were already meeting. We, the big we, not me, the individual lowly physician, meeting with department heads, legal from BJH, WashU, and have been in constant contact with them to help delineate our list and how we will document. And then sometimes even on a case-by-case basis now, we are in constant contact with legal.
Wow. Well, a lot of things happening, a lot of moving parts, but we really appreciate everything. Any other questions?
You know, if Barnes or what you made a decision that if a physician charged with a criminal charge for providing medical care, will the institution provide legal counsel?
Yes, so very important question. Will Barnes or WashU provide legal support and defense for any physician who is charged by the state of Missouri for conducting an illegal abortion? We've had those conversations with legal and things seem promising. I am not a lawyer. I cannot provide medical advice, but I can say that we are well supported.
The answer is yes.
Okay.
So just to clarify,
Yes, thank you.
BJC and WashU have very strong legal commitment to protect all of our providers who are involved in the care of patients.
Thank you, Dr. Frazier. That is my understanding as well. I just didn't want to say it.
That's
But yes,
all right.
WashU and BJH are committed to protect us.
As far as the abortion clinics in Southern Illinois, you mentioned, just could you speak a little bit to the logistics of getting our people? Is it walk-in, are they walk-in, or do you have appointments for a week period? What kind of counseling should we be giving patients when we're referring out?
Yeah, so what is the practical advice or logistics if we're going to refer a patient to Southern Illinois to have a legal abortion? So they do need to call to make an appointment. And so the easier thing to do would be like, hey, here's the phone numbers to these, or here are the names of these places, consider calling them. It is about a 1 to 2 week wait, depending on how far along they think they are, but most folks were able to get in pretty quickly. Both sites offer the full range of medication abortion for folks that are less than 77 days of pregnancy, or surgical abortion in the first or second trimester. Depending on how far along they are, it may be a 1-day procedure or a 2-day. D&Es, second trimester procedures, do require multiple days to prep the cervix prior to their surgery. So that may be something to just tuck in the way in the back of your mind, that people may require 1 or 2 days at the clinic. Otherwise, most high volume abortion clinics function such that you check in and then you kind of go through stations to get an ultrasound, get counseling, talk to financial, then finally see the doctor to get your procedure. So all told, the person may be there for 3, 4, 5, 6 or more hours. And some of that expectation setting is very helpful as well.
Any other questions? Okay, thank you so much.
Thanks, everyone.
Thank you very much. And I'll pull up the
QR code.
QR code somewhere.
So much.
Thank you.